Good afternoon, and thank you for the privilege to be part of this 15th IM postgraduate course of the Capital Medical Center. This afternoon, I'm tasked to discuss electrolyte and volume management in the intensive care unit. Hopefully, after this lecture, you would be able to describe the common conditions of sodium and potassium imbalance in the critical care unit, as well as their manifestations and how we plan to manage these patients. We'll also be touching on the relationship of sodium levels to fluid status, touch on the causes of dysnatremia and the appropriate timing and means of correction. We will also deal with potassium. We will identify the causes of potassium abnormalities and, and how to correct them and describe the association of potassium supplementation to in-hospital morbidity and mortality in the critically ill. We'll go to hyponatremia. Hyponatremia, as we know, is defined as a serum sodium level below 135 milliequivalents per liter or 135 millimoles per liter. It is important because it's the most common electrolyte disorder seen in clinical practice. Now, it can manifest with minor symptoms but can lead to life-threatening complications as well, which might include seizures and cardiorespiratory distress. It is important to tackle this issue, especially in the ICU, because around 30% of critically ill patients have serum sodium less than 134 milliequivalent. That translates to patients with hyponatremia being 7 times more likely to die than those without hyponatremia during their hospital stay. So why worry about a low sodium? When you talk about low sodium or sodium per se, let's bear in mind that serum sodium is a marker of osmolality, meaning that a high serum osmolality will pull water out of the cell and hence cause damage. On the other hand, a low serum osmolality by the way will move fluid into the cell and lead to cellular edema and malfunction. And as we will know, these are the main causes of what we see in patients with hyponatremia or hypernatremia for that matter later on. Now, hyponatremia may be classified by way of either the onset or the level of serum sodium. In terms of temporality or the onset of hyponatremia, it is deemed to be acute hyponatremia if the onset is less than 48 hours, and it is termed chronic hyponatremia if beyond 48 hours. On the basis of the level of serum sodium, meanwhile, you have mild hyponatremia if the serum sodium is 130 to 135 milliequivalents per liter, moderate if it is somewhere between 125 to 130 milliequivalents per liter, and severe if less than 125 milliequivalents per liter. Now, as we said earlier, there will be mild symptoms, but there will be severe symptoms as well. Mild to moderate symptoms related to hyponatremia may manifest as nausea, confusion, headaches, but you may have severe symptoms, and these are the basic problems that we're afraid of: vomiting, cardiorespiratory distress, CNS symptoms, seizures, and reduced consciousness or sensorium. Patients are likely to present with severe symptoms in those that have acute onset hyponatremia. Chronic hyponatremia, meanwhile, has a lower risk of neurologic dysfunction due to the brain's counter-regulatory mechanisms. So this is basically a problem of what goes in and what goes out. On the side of what goes in, hyponatremia occurs if there is too little sodium that comes in, and this you see in dehydration states, in patients with in the tea and toast diet, usually mga elderly who take nothing but tea and toast, those fond of drinking volumes of beer, leading to beer potomania, and this can also be a result of too little sodium coming in by way of poor IV management. On the other side, there may be too much water coming in, as in the case of water intoxication. On the side of things going out, hyponatremia may be a reflection of too much sodium going out as well, as in diuretic use, when you have GI losses, patients with burns, patients with decreased aldosterone or cortisol. There may also be too little water going out, in which case it's called dilutional as well, and this is because of excessive antidiuretic hormone secretion. Now, we mentioned volume. The problem with volume as far as hyponatremia is concerned is you have to determine whether they're hypervolemic, euvolemic, or hypovolemic. But this is very hard to determine. Hence, the importance of the history and physical examination of our patients. Some clues as far as PE would be your skin turgor, your mucous membranes, or in some cases, looking at the inferior vena cava as well through ultrasound. A high specific gravity or low urinary sodium, less than 30 in this case, may suggest hypovolemia, but this can also be seen in states of low effective arterial volume, as in those in heart failure. So it's very difficult to actually assess this per se. So basically, if we were to make this simple, we just have to aware that there's such a thing as volume status that we have to determine in terms of when we deal with hyponatremia, and specific gravity and urinary sodium are clues whether they're actually having hypovolemia. The important thing here is just to recognize that there are hypervolemic states, euvolemic states, and hypovolemic states. In hypovolemic states, you have to check your urinary sodium to be able to manage the condition properly. In euvolemic states, you see this in conditions like SIADH, thyroid problems, psychogenic polydipsia, and the like. And in hypervolemic states, you normally see this in edematous patients that you will see in the ICU with CHF, liver disease, or in most cases, advanced kidney disease. Now, at something with SIADH is actually a diagnosis of exclusion. So how do we diagnose hyponatremia? This is a schematic diagram of how we would want to attempt to do it. Again, the role of serum osmolality. You have to determine whether you have hypotonic, isotonic, or hypertonic hyponatremia. Isotonic hyponatremia is also known as hyponatremia. This you see in hyperproteinemia states like patients with multiple myeloma or Waldenstrom's disease, and in patients with high lipid levels. Hypertonic hyponatremia, meanwhile, are patients whose serum osmolality is more than 300 millimoles per liter. And you see this in hyperglycemic states, or states where you have an increased osmolar gap. Now, in isotonic hyponatremia, the concentration of water, the sodium concentration in water phase is not affected. However, the sodium concentration per unit plasma is reduced, leading to the hyponatremia. So the lab technicians detect this as a low sodium value. Hypertonic hyponatremia, in the meantime, there's a presence of effective solutes that cause an osmotic shift of the water, producing dilutional decreases in serum sodium. So that's as far as hypertonic and isotonic hyponatremia. But the thing here is hypotonic hyponatremia, or where you have a serum osmolality of less than 300. In this stage, you have to determine whether the urine osmolality is going somewhere, either going high or going low. If in hypotonic hyponatremia, you check your urine osmolality and the urine osmolality is less than 100 and the specific gravity is 1.005 to 1.010, then this may indicate an absence of your ADH. And you will see this in the following states like primary polydipsia, reduced solute intake. This basically just tells you that the system is becoming overwhelmed. The kidney's ability to dilute urine is overwhelmed. In patients with hypotonic hyponatremia, and you have urine osmolality more than 100, then EDH is present. In which case, you again this time check your urinary sodium in states where you have a urine osmolality more than 100, and that indicates that ADH is present. When your urinary sodium is less than 30, then that means that your renin-angiotensin-aldosterone system is active, and hence you have a reduced effective arterial blood volume. So this is true hypovolemia, hypovolemic hyponatremia. Now, in patients where you have a urinary sodium more than 30, then in this case, that's indicative of the RAA system being inactive, and then you have sodium wasting. And this can be caused by diuretic use, sodium wasting nephritis, the syndrome of inappropriate antidiuretic hormone secretion, problems with your mineralocorticoids and your glucocorticoids, and states like severe hypothyroidism. In patients who present with symptomatic hyponatremia, they should be considered an emergency and be given hypertonic therapy. Now, the treatment would be 3% normal saline, which can be given 150 ml over a period of 20 minutes. After which, you have to recheck your values, your lab values. Lab work should be obtained after hypertonic therapy is administered. The goal being to increase sodium by 3 to 5 millimoles, which should improve your patient's symptoms. Now, this is again a diagram of it. Ano? So you have symptomatic hyponatremia. They may be having confusion, nausea, vomiting, seizures, headaches. The medications that can be given at first, you have your hypertonic saline to be given 150 ml over 20 minutes. Now, if there is symptomatic improvement, then proceed with managing hyponatremia based on what caused the hyponatremia in the first place. If not, repeat your electrolytes. If sodium increased by less than 4 millimoles, give an additional round of hypertonic therapy. If sodium increased by more than 6 millimoles, evaluate for alternative diagnosis. Okay, so depending on the pathology, hyponatremia again will be treated differently. In patients where ADH is absent, hyponatremia is usually caused because the patient is simply drinking more fluids than what the kidneys can handle, as in the case of primary polydipsia. And here, in which case, the solution would be to restrict fluids. Normally, the kidneys will require solutes to create urine. So the problem there is that in patients with poor nutritional status, you expect hyponatremia, and a normal amount of water or alcohol will cause hyponatremia in these patients. In patients with reduced dietary solute intake, such as those in chronic alcoholics, they forget to eat because of being too much addiction to alcohol. Instituting a proper diet will help correct the hyponatremia. In ADH absent states, these are of particular importance because these are the patients at high risk for overcorrection, and therefore, in managing these patients, they should be monitored very, very closely. Again, in SIADH, the underlying cause should be treated concomitantly with initial treatment to raise your serum sodium. So it's one thing to raise your serum sodium in SIADH, and the other thing is to determine what possibly caused the SIADH in the first place. Again, SIADH is usually a diagnosis by exclusion. Fluid restriction is the mainstay of therapy. In patients with chronic SIADH, sodium or urea tablets can be used. Since patients with SIADH have a fixed urine osmolality, then the solute loads such as your urea and your sodium tablets are used to increase the maximum urine output by increasing the dietary solute. We're talking about correction, but in hyponatremia, if we're worried about correcting, we're also more worried about the possibility of overcorrection. As in the case of overcorrection of sodium, excessive rapid correction can lead to something so devastating, something that we call osmotic demyelination syndrome. The problem with osmotic demyelination syndrome is sometimes it has a delayed presentation 2 to 6 days after overcorrection. So you're actually overcorrecting already and you're not actually even knowing it. They may present with dysarthria, dysphagia, paresthesias, quadriparesis, and seizures which are irreversible. The MRI will show demyelinating lesions. However, this may not appear for at least 4 weeks after the disease onset already. Hence, by the time we probably recognize it, if we are not too prudent, we're too late. So what are the causes of hyponatremia overcorrection? One is treating the underlying cause itself. Okay, so we have to be very particular with what we're treating. Potassium supplementation can also cause overcorrection of hyponatremia, and of course, the use of baptans, while they are used to correct hyponatremia, improper use of these aquaretics can also lead to hyponatremia overcorrection. Other risk factors for overcorrection are disease entities like cirrhosis, poorly nourished patients, and alcoholism. We mentioned earlier that potassium supplementation is a problem in terms of sodium overcorrection. Why is this so? Administration of potassium will increase plasma sodium because it enters the cells, increasing the intracellular osmolality. And hence, when you have this, that causes water to move from the extracellular space into the intracellular space, thus raising the plasma sodium concentration by way of potassium supplementation. So now we've tackled hyponatremia, we go to hypernatremia. Hypernatremia is defined as a serum sodium above 145 milliequivalents per liter or 145 millimoles per liter. This thing is often seen in hospitalized patients and is associated as well with increased mortality in these patients that we manage. This is actually a reflection of a deficit in water in relation to the body's sodium stores, which can result from a net water loss or a hypertonic sodium gain. So again, it's a balance between water and sodium stores, volume and sodium stores. Now, most patients with hypernatremia are either the very young or the very old. And again, manifestations of hypernatremia are particularly central nervous system in origin. They lead to central nervous system dysfunction. The elderly patients, compared to the very young, generally have fewer symptoms unless sodium exceeds 160 milliequivalents per liter. Brain shrinkage happens and is induced by hypernatremia, which can cause vascular rupture, leading to cerebral hemorrhage, cerebral bleeding, subarachnoid, and hence permanent neurologic damage. This, however, is counteracted by a solute movement in the brain, which normalizes the brain volume but does not correct the hyperosmolality in the brain. So there's a counter-regulatory mechanism, but this mechanism does not correct the hyperosmolality in the brain. In patients with prolonged hyperosmolality, aggressive treatment with hypotonic fluids may cause cerebral edema. Now, as we said earlier, it's a question of water loss and sodium. The net water loss actually accounts for a majority of cases of hyponatremia. Since the sustained hypernatremia can occur only when thirst or access to water is impaired, that simply means that the groups at highest risk are patients who are unable to do this, and these are usually patients with altered mental status, those intubated, and elderly individuals. Hypertonic sodium gain usually results in the meantime from clinical interventions or accidental sodium loading. This is a diagram of how we tackle hypernatremia. Again, there will be hypovolemic patients and euvolemic patients with hypernatremia. In the case of euvolemic patients, there may be excessive water loss due to defects in your ADH release or action. In this case, the urine osmolality will be less than 300. You usually see this in patients with diabetes insipidus, whether central or nephrogenic. On the other hand, you may also have inappropriate intake or administration of hypertonic solutions. This occurs due to salt ingestion, administration of hypertonic saline or sodium bicarbonate. In patients with a sodium goal, such as those patients with with elevated ICP or increased intracranial pressure, the hypertonic saline will be routinely given to achieve this. In patients naman who are hypovolemic with hypernatremia, the loss of hypotonic solutions will need to be further investigated. And again, you go back to your urine osmolality. If you check your urine osmolality, if your urine osmolality is less than 700 to 800, then that will reflect that the hypernatremia is due to renal losses. Renal losses can be seen in osmotic diuresis, post-ATN diuresis, loop diuretics, and in the elderly due to the maximum concentrating ability. A urine osmolality more than 600 will be probably due to non-renal losses. And then what are these non-renal losses? They're gastrointestinal losses. So as far as hypernatremia, treatment will involve addressing the underlying cause as well and correcting the prevailing hypertonicity due to the hypernatremia. In patients who developed hypernatremia in several hours, rapid correction improves prognosis without the risk of cerebral edema. The serum sodium can actually be reduced by 1 milliequivalent per liter. A slower rate of correction, however, is required in hypernatremia that lasts longer than 2 days, or for patients whose hypernatremia is of unknown duration already. And then we will have to be cautious about correcting this hypernatremia. In these patients, the maximal rate of 0.5 milliequivalents per liter per hour is the right rate to prevent cerebral edema and seizures. The goal of treatment is to reduce the serum sodium to 145 milliequivalents per liter. So that's as far as us tackling sodium problems, hypernatremia and hyponatremia. So we now go to another electrolyte, another important one, potassium. Now, potassium, as we know, is essential for normal functioning of our cardiovascular system, our muscular system, our internal organs, and the nervous system as well. Potassium, as we also know, is basically intracellular in nature. The intracellular proportion of potassium represents 98% of the total body potassium. So most of it is intracellular and very little is extracellular actually. As a matter of fact, if you talk about potassium, the intracellular potassium concentration is approximately 140 milliequivalents per liter compared to what we actually are able to measure, and that is the normal serum potassium of 3.5 to 5.5 milliequivalents per liter. Yun lang na measure natin because majority are intracellular. The ratio of potassium concentrations in the cells and the extracellular fluid is important because it is a major determinant of the resting membrane potential across cell membranes. And hence, kaya ang tinatamaan are usually the organs affected by these gradients. So we go first to an excess of potassium, hyperkalemia. Hyperkalemia is defined as a serum potassium more than 5.5 milliequivalents per liter or 5.5 millimoles per liter. And this we see commonly in patients with chronic kidney disease, patients with diabetes or cardiovascular disease. High potassium intake is rarely sufficient to result in hyperkalemia. However, hyperkalemia is associated with increased mortality in patients with chronic kidney disease. We classify hyperkalemia in the following categories. Now, how does hyperkalemia show itself? Hyperkalemia can manifest with neuromuscular weakness, bradycardia, and ventricular tachycardia or fibrillation. However, in practice, most patients are asymptomatic. Again, these patients come to us, we see a high potassium value, but we cannot correlate their symptoms with their potassium values at the onset. So this is a diagram as far as how we tackle hyperkalemia, the causes of hyperkalemia. Again, we talk about excessive intake of potassium. This can be seen in patients with reduced kidney function or adrenal insufficiency because as we mentioned earlier, it's actually better rare to get hyperkalemia by way of excessive intake of potassium, unless you have a problem with your kidneys or you have adrenal insufficiency. Now, as far as the other causes of hyperkalemia, they may involve transcellular redistribution of potassium. Now, what are these? Conditions that cause tissue injury, as in rhabdomyolysis, patients who who underwent trauma, massive hemolysis, or tumor lysis. Transcellular redistribution of potassium can also occur in impaired movement of potassium across the cells, as we see in insulin deficiency, or in patients with DKA, or in patients with metabolic acidosis. Some medications can also cause transcellular redistribution or shifting of potassium. What are these? Your beta blockers, your digoxin, mannitol, verapamil. And then, of course, a decreased excretion of potassium is also a culprit as far as hyperkalemia is concerned. Now, what causes a decrease in excretion of potassium? You have conditions that decrease the delivery of sodium to the distal tubules of your kidneys. You see this in oliguric states, in patients with chronic kidney disease, in patients with cardiovascular disease such as myocardial ischemia, left ventricular hypertrophy, and heart failure. You may also have defects in distal tubular secretion of potassium, which can lead to a decrease in excretion of potassium, and you see this in obstructive uropathies, sickle cell disease, and advanced chronic kidney disease. Adrenal and mineralocorticoid deficiency, such as in Addison's disease and in syndrome of hyporeninemic hypoaldosteronemia, can also cause decreased potassium. And then again, you have medications that can cause a decrease in excretion of potassium. Drugs that affect your aldosterone secretion, your ACE inhibitors, your ARBs, your NSAIDs, ketoconazole, heparin, drugs that cause tubular resistance to aldosterone action, like your aldosterone antagonists, potassium-sparing diuretics, trimethoprim, spironolactone, and the like. Now, we said earlier that sometimes hyperkalemia may not actually be symptomatic at all, but there are ECG findings related to hyperkalemia. And as we know, this is due to the effects of hyperkalemia on cellular gradients. The EKG changes are seen with the rising levels of serum potassium. Characteristically, what you will see are from the normal ECG, you will see changes in your T waves, your P waves, your PR, your QRS complexes, and what will you see? You will see peak T waves, flattening of your P waves with prolonged PR intervals. You may have an absent P wave. Yeah, you may have widening of your QRS complexes leading to a sinusoidal wave pattern. In previous studies, they would say that certain changes will be attributed to certain levels of potassium. However, recent studies have shown that there is a poor correlation between serum potassium levels and cardiac manifestations reported. So what does this tell us? Whenever hyperkalemia is seen on labs, an EKG should be done. If EKG changes are present or the patient is symptomatic consistent with hyperkalemia, then usually this clinches the diagnosis. Potassium levels more than 6.5 to 7 are the worrisome levels. Chronic hyperkalemia is better tolerated compared to the acute hyperkalemia, which is more dangerous. So as far as managing hyperkalemia, there are actually three things that you have to consider. These three things are basically what we plan to do. Stabilize the cardiac membrane, shift the potassium back into the cell, and give agents that facilitate the elimination of potassium. As far as stabilizing your cardiac membrane from the effects of hyperkalemia, the first-line treatment options are as follows. Give your calcium gluconate. Then you may give your hypertonic saline, 50 to 250 ml of this, and this is effective in patients who are both hyperkalemic and hyponatremic. As far as shifting your potassium back into the cell, this is what we are commonly seen in our wards, not even in the ICU. You give your insulin, your glucose insulin solution. You can give your beta-2 receptor agonist. You give your sodium bicarbonate to counteract acidosis, and a combination of this is usually effective in shifting your potassium from your extracellular into the intracellular. And then after you've done this, you want to eliminate that potassium. Treatment options would include your diuretics, gastrointestinal resin binders, which could include your sodium polystyrene sulfonate, your sodium zirconium tricyclate or patrimer. And of course, if all else fails, hyperkalemia that intractable to medical management is an absolute indication for dialysis. Now, other than the level of potassium, you also have to be wary of volume status in patients with hyperkalemia. So depending on your volume status, if you need to do volume resuscitation in patients who are hypovolemic, then this is what you do. You give your lactated ringer solution if there is no metabolic acidosis. In patients with metabolic acidosis and are hypovolemic, you give your isotonic bicarbonate. Normal saline should not be used. You have to attempt caliuresis as well. Then you achieve this by way of your IV furosemides. You can combine this with your chlorothiazide. You can use acetazolamide. And if you're successful, then you go to chronic management of your hyperkalemia. Again, if all else fails, that's emergency dialysis. So dialysis with furosemide is suggested in patients with hypervolemic or euvolemic patients with hyperkalemia for the patients to be able to produce urine. Furosemide increases the urinary excretion of your potassium, which can be used both in the acute setting of hyperkalemia or chronic management. Dialysis, in the meantime, should be considered in patients who fail medical management or will have persistent EKG changes. So that's as far as hyperkalemia and its management. Now, what about hypokalemia? Hypokalemia, in the meantime, is a low value of potassium less than 3.5 milliequivalents per liter. It's life-threatening as well when you reach potassium levels below 2.5 milliequivalents per liter. A vast majority of potassium, as we said, is located intracellularly. And therefore, hypokalemia is often due to a large total body potassium deficit. Now, again, you classify this according to mild, moderate, and severe. Now, usually, that's the time when clinical features come in terms of hypokalemia, when the potassium values are 2.5 milliequivalents or below. And what are these? These include cramps, muscle weakness, muscle pain, easy fatigability, constipation, syncope, and palpitations. Again, with hypokalemia, if you see this in hyperkalemia, ECG changes, you see EKG changes in hypokalemia as well. And what are these? You may see decreased T wave amplitudes, ST segment depressions, a presence of a U wave uh, can also indicate hypokalemia. Giant U waves may be mistaken for peak T waves sometimes, ano? So other findings may include QT prolongation, ventricular extrasystoles, and of course the dreaded ventricular arrhythmias. Now the goals of treatment. Of course, the goals of treatment would be these three things: to reduce further losses of your potassium, to replace what is lost, and to evaluate potential toxicities and treatment of the underlying cause. Due to the intracellular nature of potassium deficit, intravenous potassium must be administered slowly and time is required for potassium to enter the cell. Rapid administration may cause serum levels to be elevated even though there is a total body deficit leading to serum hyperkalemia. It should be noted that when you give your potassium, you give it intravenously pagka ganon, ano? The target potassium is 3.5 milliequivalents per liter. Traditionally, the potassium goal would be 4 milliequivalents per liter and this was used to reduce the risk of arrhythmias. However, in recent studies and the large studies, they have shown that the safest potassium level in myocardial ischemia is actually somewhere between 3.5 to 4.5. Now, with evidence of higher or lower levels correlating with lousier outcomes than at these levels of 3.5 to 4.5. In the case of DKA, with the absence of renal dysfunction, the target potassium level would be more than 5.3 milliequivalents per liter. Now, enteral potassium repletion or replacement is actually prepared compared to the IV route simply because, well, number one, it's cheaper. Number two, it's safer and does not irritate the veins. Potassium chloride, of course, is the most common used formulation and are especially useful with metabolic alkalosis and increases your sodium, increases your serum chloride. Now, slow release formulations are suboptimal if you want immediate effects. However, the slow release formulations naman are better tolerated. So pagka lang hindi ka naman masyado nagmamadali, then you can use the slow release formulations. Another formulation is potassium citrate, which may be useful in non-anion gap metabolic acidosis. In this treatment strategy, the citrate will be converted into bicarbonate, thereby improving the acidosis. IV potassium can be used when there is lack of gut or GI function or access and severe hypokalemia is in need of emergent treatment or in cases of profound shock with severe hypokalemia. The rate of administration is 10 milliequivalents per hour through a peripheral line or 20 milliequivalents per hour through a central line. We give this as a drip. It has to be given at a very, very specific rate. The rate of administration being at your front now, ano? 10 milliequivalents per hour through a peripheral line and 20 milliequivalents per hour through a central line. When IV repletion is more than 20 milliequivalents per hour, then it is imperative that you do cardiac monitoring. Now, outside of just treating the potassium, one thing very important when you talk about hypokalemia is that it's not only the potassium that you should be worried about. Magnesium has to be checked and should be repleted as well because failure to treat this will make it very difficult to fix the hypokalemia. In patients with ongoing GI losses, an initiation of your proton pump inhibitor may minimize your electrolyte derangements. So in the past so many minutes, we've tackled two electrolytes important in critical care, sodium and potassium, and hopefully with this short discussion, you'll be able to further address patients in the critical care unit as far as their sodium and potassium derangements and will probably be helpful in how we will probably be able to save a lot of these patients from this dilemma. Again, thank you for the chance to be a part of this academic forum.